Hello, everyone. Welcome and good evening to tonight's National Keratoconus Foundation evening webinar. We have a very special speaker tonight. Our topic will be updates on dry eye and keratoconus. So a very relevant and pertinent topic to all of us. I would like to introduce our special guest speaker. Her name is Dr. Melissa Barnett. Her bio is like a book, so I'm going to summarize it a bit for you all so that she can give her talk today. Dr. Melissa Barnett is a principal optometrist at the University of California, Davis Eye Center in Sacramento and Davis, California. She is an internationally recognized key opinion leader specializing in dry eye, specialty contact lenses, and presbyopia. She lectures globally and publishes extensively. She serves on the board of the Gas Permeable Lens Institute and is past president of the Scleral Lens Education Society. Together with Dr. Lynette Johns, Dr. Barnett authored and edited the book titled Contemporary Scleral Lenses, Theory and Application, with unique perspectives and contributions of international experts. Dr. Barnett was granted the Most Influential Woman in Optical from Vision Monday in 2019, and she, along with Dr. Tom Arnold, are co-hosts of the popular podcast, Global Eyes. So without further ado, I would like to introduce Dr. Barnett, and just a couple reminders. We will be taking questions, so feel free to enter your questions in the comment section. We will get to your questions midway in the talk as well as at the end. So enjoy this talk, and I will hand it over to Dr. Barnett.
Well, thank you for the warm introduction, and thank you all for joining us tonight. This combines like two of my favorite topics, dry eye and keratoconus. So really, I would love to answer all your questions. Feel free to type them in the chat. I'm going to go over a variety of topics, and hopefully you'll learn something, and hopefully you'll take home some information that will actually help you out. So let's start. Here we are in January 2022, and we have mask-associated dry eye. Face masks are used, as we know, to reduce COVID-19. And there's been a huge increase. We're all seeing this huge increase in dry eye over the last 2 years, because many of us, myself included, need to wear face masks all day long. And when we're wearing face masks, even those of us who did not have dry eye have more dry eye with face mask wear, and we're finding a lot more infections in the last 2 years of the eyelid. So why are face masks causing all this dry eye, and what can we do? So these are some tips you can take home and hopefully use for yourselves. So face masks actually have that drying effect on the ocular surface when hot air blows upwards instead of outward. It increases the tear film evaporation, and the tear film is so important. There are so many proteins in the tear film. The tear film bathes the ocular surface. It has this wonderful effect of homeostasis, like this magical property that helps prevent irritation and discomfort, and also really helps with good vision as well. And poorly fit face masks are often the cause and can contribute to mask-associated dry eye. It's MADE. So what can we do? We can tape the top of the mask. We've been doing that a lot in clinic. You can use surgical tape, just a little bit up top, but it's fine to wear just a little bit of tape if you're okay with that, out and about as well. We don't want to pull too much on the eyelids. That can cause incomplete eyelid closure. So just a gentle little taping up top. It's helpful to have masks with pliable nose wires to really conform to the nose so that hot air doesn't blow up. We can use lubrication. So my preference, as you'll see in a little bit, is non-preserved, so preservative-free eye drops, the ones in the little individual vials, versus an eye drop that's in a bottle with a preservative like BAK, which can make the eyes more dry. We want to limit the time in air conditioning, and right now in the cold winter months, and heaters as well. We want to take lots and lots of breaks on digital devices, and remember to drink water. So continue to drink water during the day. And taking the breaks, it's the 20-20-20 rule, which I'll get into in just a moment. So we're also on digital devices so much, not only us, but children with remote learning. Even my kids, I have 2 kids, they're 13 and 15, they're in school, but they're on their digital devices in school. And we're on digital devices many, many hours per day. So for example, millennials are on their digital devices 34 hours a week. If you look on your phone, you can actually see your screen time and how many hours a day you're on your digital device. It can be a little bit scary. The meibomian glands are really important, again, to provide that healthy tear film. And blinking, actually the nature of blinking is really important to distribute the tear film and have that beautiful property there to prevent dryness. With digital device use, it really increases dry eye. We don't blink as much. We actually blink 5 times less than those who are not using digital devices. And there are many different visual complaints like eye strain, dryness, burning, blurred vision, even at the end of the day, and irritation. So you might be fine in the morning, and at the end of the day, you notice that you're needing to blink more, the vision's blurry, the eyes burn or sting, and dry eye has been shown in multiple studies with digital device use. It's that reductions, we're not blinking as much and we're not blinking as strongly and completely, that is associated with dry eye symptoms in those who use digital devices. And those beautiful meibomian glands that I just showed you in the last picture, they can become plugged up and you can see this toothpaste-like appearance here. And it's meibomian gland dysfunction that we see very, very often that contributes to dry eye. This was a very interesting study looking at those who had to press the space bar on a computer when doing a task, a high cognitive demand task, versus those who are just watching a movie, and showed that those who were actually doing a high cognitive demand task had more dry eye. And what are we all doing? You know, even our just day-to-day work, we're doing these high cognitive demand tasks leading to more dry eye. So different things that you can do. We can all have our working distance about 90 centimeters or 35 inches. We want to gaze down a little bit, about 10 degrees when we're looking at digital devices, blinking exercises, so actually physically blinking the eyes and adding in a desktop humidifier. We all should use the 20-20-20 rule. So that is taking a 20-second break every 20 minutes and looking 20 feet away. That's something that is not a digital device. So we don't want to look away at a TV or something like that. We actually want to blink our eyes and go outside, take a little walk, look at something very far away. Taking breaks on digital devices is very important. We also want to add in a humidifier. Now, this is something we probably don't talk about enough, but adding in a humidifier at work, at home, at night really helps. So we have that optimal humidity from about 40 to 55%, especially right now when it's cold inside many places, and also other times when in places that are quite dry, adding in a humidifier can be very helpful. Now, what about allergies? So I'm in Northern California, and we have tons and tons of allergies all year round. I actually live in one of the cities that has one of the most trees in the country, which are wonderful, but many people with keratoconus also have allergies. So we know that there are various conditions associated with keratoconus, one being vigorous eye rubbing that we want to avoid altogether. Ocular allergies, so allergies in the eyes, and we have different strategies to help there. Eczema, floppy eyelid syndrome. So I like to ask my patients if they have any trouble sleeping at all and evaluate for floppy eyelid syndrome. So I lift the eyelid up. And so that's something that I like to work up and diagnose and manage with other specialists, the sleep apnea if it exists, Ethnicity is associated with keratoconus and also pregnancy, but here I'm just focusing on allergies because unfortunately I only have 1 hour to talk to you about dry eyes and keratoconus, where I would love to talk to you for 8 hours or something like that, but focusing on allergies here. So allergies are very prevalent. I see allergies every single day. They affect as many as 30% of adults and 40% of children. And it's actually the 5th leading chronic condition in industrialized countries for all ages, from kids to adults. And the 3rd most common chronic disease in children. And eye-related allergies can also really affect contact lens wear. So we want to manage allergies. There are many different things we can do. We don't necessarily want to take an oral medication to manage ocular allergies. This is just an example of a few eye drops that are available for ocular allergies that we can use to manage. And some of these are over the counter. So for example, the Pataday drops are over the counter. The one in the middle is becoming over the counter very soon. And there are some other topical over-the-counter allergy eye drops that can be used as well. We can also use preservative-free artificial tears. I love refrigerating everything. So put the drops in the refrigerator, put the tears in, put the allergy drops, using a cool compress, so using a nice cool cloth on the eyes really helps manage allergies. Now, other things we can do to manage allergies: taking shoes off before going in the house, or for kids especially. I know when my kids were little and they're rolling around in the grass, I'd have them take a shower or a bath when they came inside to just wash all the pollens out. But we want to manage allergies early because they can all lead to a lot of inflammation. And the most important thing, takeaway, is to not rub the eyes, because that can really increase inflammation and cause a lot of issues there. So associated with allergies, and you might say, this is a little bit interesting, but we now have genetic testing for keratoconus, because sometimes I'm seeing patients in clinic and I ask them and also their children if they have any allergies, if there's any eye rubbing, and I become even more suspicious for the diagnosis of keratoconus. So this genetic test checks both for keratoconus and for corneal dystrophy. So here I'm just focusing on keratoconus because that's what we're talking about tonight. There's 75 related genes for keratoconus and more than 2,000 keratoconus-related gene variants. So in this test, it's actually a simple cheek swab of the mouth. So this could be done in babies, it could be done in kids, it could be done in everyone. And it's something that we're using much more for children of those who have keratoconus, those who have keratoconus to see what specific genes they have, and partners and family members in the clinic. So it's very easy to use. And here's just an example of the test. And it gives a risk assessment for keratoconus. So it's helpful in our practices when we have certain signs, certain symptoms, other diseases and conditions associated with keratoconus. And it's one more piece of information that is quite helpful when we're looking to make that diagnosis. So it goes hand in hand with allergies. Okay, moving on to scleral lenses. And scleral lenses are used for many different conditions. And scleral lenses, for those of you who don't know, they were actually the first type of contact lens that was introduced. So they were made in the late 1800s and early 1900s, and it was really difficult to reproduce the lens. It was hard to make the same exact lens time and time again. And at that time, an impression was made of the eye, as you can see in the upper left, and of interest, impressions are made today also of the eye. That's one way of designing a scleral lens. The lenses today are made of really fantastic materials that can provide a lot of oxygen, more than ever before, to the ocular surface. They're very reproducible, and we have all sorts of options and customizations that we can do with our lenses to make them look just beautiful, like this one here. So there are main scleral lens indications, and one is visual rehabilitation in those who have irregular corneas like keratoconus. Scleral lenses have this fluid reservoir, so they're used to treat ocular surface disease. They can also be used for those who have refractive error, people who are nearsighted or farsighted. And the beautiful fluid reservoir between the lens and the eye, as you can see here in that greenish area, is what bathes the eye all day long. So scleral lenses are used for those who have dry eye and keratoconus as well. And I see that a lot in my practice. I think a lot of us do, because scleral lenses can really hydrate, bathe that ocular surface. They protect the surface of the eye. And general considerations are just how to insert the lens, how to remove the lens, and care and solutions that I'll talk about in just a moment here. So scleral lenses are used with other products. So different eyelid cleaners and eye drops, and that's coming up in just a few slides as well. So say you're on a topical eye drop like Xiidra, it would be appropriate to continue that drop with a scleral lens fitting. And then I like to see, how the eye's looking, how the symptoms are, and perhaps stop or perhaps continue. Scleral lens solutions are so incredibly important, and I'm going to talk about different solutions that are available with scleral lenses because I've gotten a lot of feedback from not only my patients, but just other people with keratoconus who tell me that something that I mentioned to them about a solution or something that they read about a scleral lens solution has really changed and improved their dry eye. There are different types of solutions. So there's application solutions, solutions that go in the bowl of the scleral lens. There are disinfection and storage solutions and additional cleaners. So I'll get into all of that in just a moment, because this is something that we don't want to see. Here you can see a toxic reaction on the cornea because there are many different preservatives and active ingredients in all sorts of solutions. And those of us who fit a lot of scleral lenses see incorrect solutions being used. So I want to make sure any of you who are wearing scleral lenses are fueled with the tools for success to use exactly the solution. And most importantly, if you wear scleral lenses, to talk to your doctor about these solutions. So preservative-free solutions are very, very important. There are many solution complications. Lenses can be uncomfortable, either initially or after hours of lens wear. It might be not comfortable wearing lenses for as long as possible. So I like, a full day of lens wear, which could be 14, 16 hours of lens wear versus 6 hours of lens wear. The eyes can be red or itchy, and by using preservative saline in the bowl of the lens, it can really help improve the ocular surface and help with dryness. Preservative-free cleaning solution, like a hydrogen peroxide solution, is also beneficial. So here are just some other signs. So here are all the solutions, and let's talk about them. So years ago, we didn't have any FDA approved solutions, and sodium chloride 0.9% inhalation solution was used because we really didn't have much of anything else. And this solution does not have buffers, it does not have preservatives. At this point in time, it is off-label use. It does come in 3 ml or 5 ml vials. And what I've seen in my practice is that a person could be using this solution time and time again, they're doing just fine. And then for whatever reason, it's just not working. Lenses are uncomfortable. The cornea looks like the picture you saw a few slides back. And I have a bunch of patients at the same time who came in. This was before the other solutions existed, and it was the pH. So it was actually, the solution was a little bit different than it was the month before. So now we have FDA approved solutions, and we have many of them. So Lacropure from Menicon, this is a solution that does not have any buffers, no preservatives. It's an FDA approved option. It does come in a 5 ml vial and available in a box of 98 vials. Sclerofill has a buffer. It does not have preservatives. Again, FDA approved. This comes in a 10 ml vial, available in a box of 30. Now, the important thing for all of these preservative-free solutions is that they should be used, and they can be used for rinsing of the lens. They can be used in the bowl of the lens for applying the lens, but they are preservative free, so they do need to be disposed of or recycled. They can be recycled after a single use. Neutrophil is kind of a unique solution. This one contains electrolytes. It is also an FDA approved solution in a 10 ml vial. One of the more recent ones, Vibrant View from ABB, is a non-buffered solution without preservatives, comes in a 5 ml vial. Pure Lens, which is a solution in a bottle, can be used. However, our wonderful moderator here actually did a study on this and showed the high rates of contamination with patients who came in with this solution. So it is not my preferred solution that I use in my practice, but it is something that can be used for rinsing. Yeah, oh, it's just, yes, Pure Lens is 4 ounces. Excuse me, it's not 4 ml. Neutrophil. So neutrophil is a sort of special newer solution. It is an electrolyte supplemented solution that has potassium, calcium, and magnesium in it. It is a phosphate buffered solution, and in a really great study here, they showed a significant improvement in burning and stinging, in grittiness, and basically better vision and better comfort in those who use this solution. So it's been a really nice addition for our scleral lens practice and has helped with things like fogging behind the lens. So here you can see fogging both behind the lens and also on the front surface of the lens. So this is what a lens looks like that has a lot of debris there on the front surface of the lens. And of course, that can cause blurry vision. And it's a hassle to remove the lens and then put it back in during the day. No one wants to do that, especially those of us who wear eye makeup. That's kind of a pain. So there are many different methods for addressing surface deposits, and it seems like year after year we become a little bit more limited in some of the options. So for example, the Optimum Extra Strength Cleaner is not available. We do have MiraFlow that was gone and now it's back. So it's an alcohol-based cleaner that can be used to rub the lens. We also have Serene, which is a cleaner on the surface of the lens. And these are alcohol-based cleaners that require manual rubbing. Now, for those who have Hydropeg, which I'll talk about in just a second, on the lens surface, we don't want to use any of these. Especially, we do not want to use Metacom Progent because that will remove Hydropeg. But if a lens does not have Hydropeg, we can use Metacom Progent, which is a combination of 2 sterile solutions soaked for 30 minutes to really remove deposits. So that works really, really well and helps with dry eye. Plasma treatment is something I use on all my corneal lenses, and I fit a lot of corneal gas permeable lenses and all my scleral lenses as well. So it helps the wetting surface on the front surface of the lens. It makes the lenses more comfortable and reduces fogging also. But now we have tangible Hydropeg, which is a surface treatment that improves wettability. It increases surface water retention, improves lubricity, so it makes the lens surface more slippery and smooth to resist deposits, and it helps with fogging of the lens, both the surface of the lens and behind the lens. So I'm going to share this video with you, and I always like to think about the gooey stuff as mascara. I love to think about that. So here you can see 3 different lenses. The first lens is an uncoated lens, and you can see dipped in the gooey mascara stuff, and you can take a look at that lens. The second one is the plasma treated lens, and in a moment you're going to get to see the Hydropeg treated lens. And then we're going to get to see all 3 together. and the uncoated, plasma treated, and the one treated with tangible Hydropeg. So it's been a game changer. It's been really helpful for many of my patients in my practice having tangible Hydropeg. So we actually did a study. I did a study along with two of my colleagues looking at scleral lens wearers with dry eye, comparing lenses with this tangible Hydropeg to lenses without tangible Hydropeg. And those with tangible Hydropeg had better comfort, less dryness, and their front of the eye was less dry and they felt better. So it was a really interesting study that we did there. And those who, when we use tangible Hydropeg, we do not have to change the lens fit. We don't have to change anything at all. It can be used on all sorts of lenses, but it's especially helpful for those who have dry eye, those who have dryness or discomfort with lens wear, those who have all those deposits, as you saw on the surface of the lens, and those who have fogging of the lens. Now, keeping the solutions really simple is important. So we could use either a multi-purpose solution or a hydrogen peroxide solution. So the multi-purpose are tangible clean, unique pH or Boston Sim Plus, hydrogen peroxide or Clear Care or Clear Care Plus. And these solutions need to be soaked for 6 hours or overnight. Things that we do not want to use with Hydropeg, we don't want to use water because it's abrasive and it actually can take off that Hydropeg coating. We don't want to use any abrasive cleaners like Boston Advanced Cleaner that has little silica like is in toothpaste that can take off the Hydropeg. We especially don't want to use any alcohol-based cleaners like Miraflow or Menacom ProGent. So we want to keep it simple. And I know in my practice, we were using so many different cleaners prior to Hydropeg being introduced that the most complicated thing was actually just removing all of those and keeping it very simple. But now, new, we have Tangible Boost. And the way I like to describe this is that it re-hydropegs the surface of the lens. So it actually maintains that polymer chain supplement and rebuilds the coating that can be affected with lens wear over time, because we find that the Hydropeg does wear off over time, especially in those who have dry eye. Tangible Boost can be used once a month with lenses that are Hydropegged. It is FDA approved and it is a prescription product. But here I'm going to show you a video that is really nice about how to use Tangible Boost.
In this video, we will explain how to use Tangible Boost. Tangible Boost is a brand new monthly conditioning solution designed to restore the tangible Hydropeg coating and maintain its benefits for the life of the lens. It is also a prescription-only product. Now, let's get into the step-by-step instructions. When you open your brand new Tangible Boost kit, it will contain one lens case, instructions, and a foil pouch containing the Tangible Boost solution. The first step is to combine both Tangible Boost solutions in the Tangible Boost case. Next, you will clean your lenses by rubbing in Tangible Clean multi-purpose solution for 20 seconds. You will then soak your lenses in the Tangible Boost solution for 30 minutes. After soaking, you will dispose of the Tangible Boost solution, fill the lens case with Tangible Clean multi-purpose solution, and submerge your lenses for 20 seconds to rinse. After rinsing, you will disinfect your lenses using Tangible Clean in their standard lens case overnight. Do not put your lenses in your eye prior to disinfection with your multi-purpose solution. And that's it. After completing those steps, you have successfully boosted your tangible Hydropeg coated lenses for the month. If you have any other questions about ordering Tangible Boost or need clarification on any of these steps, feel free to visit our website, tangiblescience.com, for more information. See you next time.
I think that's a nice video because some of my patients think, oh, it sounds complicated, but it's really not. So it's just going step by step. And the Tangible Boost really does help with dryness over time of lens wear, and not only for scleral lenses, but also for corneal gas permeable lenses. So now I'm going to talk about different management strategies that can be used to make the eyes feel more comfortable with contact lens wear or even without contact lens wear. So one are warm compresses, and warm compresses can be done in a multiple ways. So they could be done with a warm wet washcloth or a potato or a tea bag or a hard-boiled egg, or you can make a whole meal out of it. You can see this little rose-like pattern that's multiple washcloths all together, but I tend to like commercial warm compresses because they stay warmer longer. So here's an example of a few where they are heated up in a microwave for about 20 seconds and they stay warm for at least 10 minutes. There are also warm compress types that don't need a microwave because I find some people don't have a microwave and they can just be clicked and get warmed up. Now, this is a study that I like to tell not only my patients, but also myself to really encourage myself to do my warm compresses. This is looking at the Bruder warm compress in those who had contact lens related dry eye and showed that by using a warm compress, it increased comfortable wearing time of contact lens wear by 3 hours. So that's a nice take home point that you can use as well. There are multiple solutions for dryness, and these can be done even with contact lens wear. So we have drops like Restasis, we have Xydra, we have Sequa, we have Regenerized drops, and the newest thing on the market, it's called Tyrvaya. So this is a nasal in the nose stimulation that increases the tears to help with dry eye. And really, so far, so good. I've had many patients that like this option. And for those of us who wear contacts and maybe wear makeup or just didn't have relief with some of the other options, it's been very helpful in our practice to help with dry eye. There are all sorts of goggles that can be used. So there are daytime goggles, there are nighttime goggles. For those who have a CPAP machine, goggles are quite helpful. And just a little gentle reminder here to add in that humidifier, both during the day and also at nighttime, which can help with ocular dryness. Now, there are many different products that can be used. And I do recommend instead of baby shampoo, because looking at the studies, commercial products do tend to work much better. But there are many different products that can be used for eyelid cleaning and warm compress. Now, this slide is a reminder to check products, so not just makeup products, but also sunscreen and also moisturizer. There's a really nice website, the Environmental Working Group, EWG, Skin Deep, and you can put your products in there and it can tell you if they're safe or not. Because what we're learning here is that there are many products in makeups and face screens and sunscreens that can lead to increased dryness of the surface of the eyes. Now, the good news is that we have a lot of new products and new options that are safe and healthy for those who wear contact lenses and also who have dry eyes. So you can see some of them here. The picture on the left, it's called 2020 Beauty, that just came out. The Evertears also just came out, and this is not a makeup, but it's a little pad that you can click to warm up, and it also has an eyelid cleaner there. Eyes Are the Story has multiple products, and We Love Eyes. There are a few products here at the bottom from Eye Eco, which is a great company that help with different products for those with dry eye. We have different eyelid cleaners, as you can see, from multiple companies, and there's a facial spray. So here are just some examples of things that can be used to help with ocular dryness. Now, what about our diets? I feel like I'm talking a lot in my day-to-day about diet because it is so important when we talk about dry eye and comfortable contact lens wear. So our diets typically in this country are more inflammatory. So we do need some pro-inflammatory prostaglandins to fight off infection, diseases, and a whole host of conditions. But really the ideal ratio of omega-3 to omega-6 is kind of off in this country. And the ideal ratio of omega-6 to omega-3 is 4:1. But the standard American diet is closer to 25:1. So then we have more and more inflammation And we have this chronic inflammation, which affects dryness as well. So I searched this just the other day for this lecture tonight, and the typed in diet and dry eye, there are 279 results. So what diet is best for dry eye? Now, good news, I'm not going to tell you to go on one specific diet, because there are many different studies looking at all sorts of different diets and dry eye and how it affects the surface of the eyes. But what I will recommend is a diet that is lower in protein and fat and cholesterol, has a combination of increased in complex carbohydrates, has good vitamin A and zinc. Also, vitamin B6 and vitamin D are very important. There are lots of studies on turmeric and dry eye, and turmeric can actually help with dry eye. You can either eat it or take a supplement. I am a big fan of omega fatty acids, so fish oil by mouth for dry eye to help reduce inflammation, something like Hydropeg. We want to make sure that we're drinking enough water. Fortunately, the studies say a little bit of caffeine is okay. We just don't want to overdo it with too much caffeine. We want to reduce the sugar and salt intake and make sure that we're hydrating throughout the day. Now, the future is really the microbiome, like in so many other specialties. So having specific things that we can do to help with inflammation and dry eye on the ocular surface. And it'll be really exciting in the next few years and to see what that brings. So I would love to answer your questions. And do we have any questions here?
All right. Yes, we definitely have questions. And I have to say, wow, you just gave us so many wonderful clinical pearls that I am sure everyone attending is very excited, and I myself have learned a lot too. So let me get to a few questions here. So starting with, what happens if I rub my eyes because it itches? I know you talked about itching and allergies and keratoconus, so let's start with that.
Sure, yeah. So what happens with the rubbing of the eyes is that inflammation. So it's actually a whole inflammatory pathway. And it's not just the eye, this goes back to the brain as well. So allergies and dryness and eye rubbing, they go hand in hand, and it can increase inflammation. So if you accidentally rub your eye, which can happen, it's not the end of the world. But what I would recommend is, one, make sure your hands are nice and clean, and try not to rub the eyes if possible, but use some artificial tears. So just kind of rinse everything out, use those preservative-free artificial tears. If you're a contact lens wearer, you can take out and put back in your contact lens, especially a scleral lens, to refill it, and use an allergy eye drop, and using the eye drop and then waiting about 10 minutes and then putting in the contact lens.
Great. Great pearls. I never thought about rinsing the eyes after you rub, but it makes sense, because if you're releasing inflammatory mediators, you want to rinse them away. So another question on a specific type of eye drop, what's your opinion on the preservative-free eye drop Refresh Relieva? Have you tried that?
Oh yeah, so Refresh Relieva, I'm a fan of it. If you're a contact lens wearer, I would like that one, or the Optiv are great, or TheraTears as far as the preservative-free without contact lenses. The Optiv Mega 3 is a great one. There's so many good ones out there. There's Oasis Plus that works very well, but I like that preservative-free Refresh Relieva.
Okay, great. So a couple questions relating to specific types of contact lenses for keratoconus patients. One is, can you explain the difference between scleral lenses versus Rgps?
Yeah, sure. So scleral lenses, they go over the cornea and they land on the scleral conjunctiva. So there's actually this fluid reservoir, this fluid layer between the lens and the eye, versus a corneal rigid gas permeable lens that's a much smaller diameter, it's a smaller size, and it goes on the surface of the eye, so it moves around a bit with the blink. So scleral lenses are very stable. They sit in one spot, they have this fluid reservoir, and a corneal gas permeable lens moves around. Now, the good news with both of them is they have very, very good optics because they have the rigid gas permeable optics, so they provide really good vision. And it is possible, even if you've worn a corneal RGP for many years, to transition to a scleral. But I'm not saying that everyone needs to, but those who have kind of moderate to severe dry eye, it's something that could be helpful.
I find this topic to be very interesting. Obviously, you fit a lot of scleral lenses as well as RGPs, but I'm just curious. Obviously, I'm a huge fan of scleral lenses as well, and I would say the majority of the patients in my clinic wear a scleral lens. But what are you seeing and what are you doing these days for your keratoconus patients? Do you find yourself using more RGPs, more sclerals? Is it dependent on the particular patient? And then do you find that your keratoconus patients in one lens or another might have more or less dry eye symptoms?
Sure. So we have lots of tools in our toolbox, which is great. So I would include custom soft lenses for keratoconus. We have hybrid lenses for keratoconus. We have RGP lenses and we have scleral lenses. And a lot of it so I do a combination, and I think a lot of it really depends on dryness. Some of it depends on if a corneal transplant has been done and if there's corneal edema or swelling of the front of the eye as well. But if someone has a really dry eye with keratoconus, I'm going to reach for a scleral lens. And if the eyes are not dry and the eyes are pretty good, or if I can manage the dryness in a different way, I could easily reach for a corneal gas permeable lens. But I also use custom soft lenses and sometimes hybrid lenses as well for my patients with keratoconus. So it really depends on the person, and some of it depends on what's been tried before, what worked, what didn't work. Sometimes it's changing the fit of the scleral lens or the corneal GP lens or whatever lens it might be, or changing the solutions, or changing the other things that are done to manage the ocular dryness with contact lens wear.
Got it. So in short, we have a lot of tools and
Yes.
a lot of combinations that will work differently for different people. So another question, one of our attendees asked, I had scleral lenses and had issues with peripheral vision, like light starbursts. Is that common and can it be fixed?
Yeah, so the wonderful thing about all these lenses is that they're so customizable. So we can change so many different things, so many different parameters, and they're really customized and individualized, which is what I love. So that's not super common, but there are lens design changes that I would make in that situation to reduce the glare and flare, especially at nighttime.
And the patient didn't include this, but I think also we should comment that if they have corneal scarring, that may also contribute to changes in optics, glare, starburst at night, and that's something that's hard to control even with the optics. But it is very exciting with all the tools we have. And I know we didn't get into this probably because we don't have 3 hours, but we also have, as you know, correction of higher order aberrations that can sometimes be helpful in patients with keratoconus. But again, if you have central opacities, that makes it very challenging to correct some of that.
Yeah, I totally agree with the HOA correction as well. So there are many different options. Totally agree with you.
Okay, so now a couple questions on solutions. Can you use neutrophil on RGP lenses?
You could use neutrophil on RGP lenses to rinse the lens if you wanted to. And this leads to a really good point, is that we don't want to use water at all. So we want to avoid rinsing all lenses. We don't want to use water to rinse any lens, whether it's a RGP lens or a scleral lens. And so, yes, something like neutrophil could be used, but you're probably not going to get as much benefit out of it on an RGP lens versus a scleral lens. One thing that I didn't include on that fogging slide also when it comes to solutions is that we can use a thicker or more viscous lens, which I use a lot for dry eye and keratoconus. in the bowl of the lens along with the solutions I showed you. So for an example there, a preservative-free Celluvisc, I could start with 2 drops of that along with an FDA approved solution in the bowl of the lens and then putting that in. It is fine to use 100% of a thicker drop. Another option is Oasis Plus in the lens bowl along with another solution, and that can really help with the not only dryness but the fogging behind the lens as well.
Great tip. I've definitely recommended using the Refresh Celluvisc within the bowl, and it's been very helpful in some patients. Now, it doesn't eliminate the clouding for everybody, but for some people, they feel more comfortable. They say it feels more lubricated, and it can sometimes help with the fogging. So another question, am I correct that Hydropeg is only available on Contact plastics?
Well, a few years ago, but now we have many different materials. So most materials from most labs can use Hydropeg at this time. So kind of came out, when Hydropeg came out, it was first in Scleral Lenses, it was one lab at a time across the world. And now it is much more available on most materials, so even non-Contact materials.
Good to know.
Mm-hmm.
So what do you think about punctal plugs for dry eyes?
Yes, so punctal plugs are an option if the eyelids are kind of clean and healthy. So for example, if there's severe plugging of the oil glands, meibomian gland dysfunction, if there's a lot of inflammation going on the ocular surface, I don't tend to reach for punctal plugs. If the eyelids look pretty good, then I can reach for punctal plugs and they can be beneficial. So what I like to do really is clear up all of the blepharitis and meibomian gland dysfunction first, and then consider punctal plugs. Now, in scleral lens wearers, sometimes a plug can help if a plug is not in, but sometimes a plug can make the inflammation worse if a plug is in. And a good trial is trying a temporary one first. So we have temporary plugs that dissolve in about 2 weeks. And if that provides relief, then we can move on to permanent plugs and to provide more long-lasting relief. So that definitely, punctal plugs are definitely an option that are available. And there are different types of plugs. So ones that go all the way into the puncta, the little holes, and ones that have a little lip on top. And so sometimes if one goes all the way in, you can't really see it, but other times if there's one with a little lip, you can see that.
Very true. So in regards to Restasis, there is the multi-dose bottle and then also the individual tubes. Someone's asking, does the bottle contain preservatives?
Great, yeah, these are great questions. So no, the multi-dose bottle does not contain preservatives, Restasis. There's been so much advancement really in the last few years. So there are many different multi-dose artificial tears along with, say, the Restasis multi-dose that do not have preservatives. So it's more a personal preference sort of thing. In the vial of Restasis, the single individual vial, there are about 8 drops, so there's a lot in there. So some people like having a bottle, but some people prefer having a vial for things like traveling and things like that. But both are preservative free and both are the same formulation.
Very good clarification. So we have about 12 minutes to go. We've answered a lot of great questions. Thank you for that. So I am going to let you finish up your talk, and then if we have any more time, we might take a few more questions at the end.
Actually, I left extra time because Taylor asked me to leave extra time for questions. So the talk is done. I am here to answer all the questions.
Awesome. Okay. Yes. So we do have a couple more. And you just touched upon avoiding water when rinsing and handling your lenses. So someone asked, is it okay to use water to rinse the RGP or sclerals at any point? And I have this dilemma myself because Look, if you're using sclerofill or Lacropure or one of the little vials and you're rinsing off this very sudsy soap, you're going through a lot of vials. What do you think about, rinsing off the soap with tap water, but then rinsing again with saline before putting in your eye or before storing?
Yeah, so I'm kind of a no water kind of person here. So it's because of the risk of acanthamoeba. And if you go back to the literature and all the studies, and I mean, I understand that. So I would be okay with using like a sodium chloride for rinsing because it's a little bit less expensive than some of the other products that are available there. But I would really like to avoid water. Now, something I didn't get into a lot here, but let's talk about hydrogen peroxide solution because I am a huge fan of hydrogen peroxide solution. It really cleans and disinfects lenses very, very well. And it's just that soaking for 6 hours or overnight. And then the saline, it neutralizes into saline. So there's not a lot of rinsing that has to be done. No rinsing at all. You could just rinse it with the application solution if needed. And there was a study that came out just a few months ago showing the benefits of this solution, so hydrogen peroxide, for COVID. And so I've been a huge fan. I've been a huge fan for many, many years of hydrogen peroxide solution, but I'm a little bit more of a fan right now because of this one study that just came out.
I myself am a huge fan of peroxide systems, and I have a lot of patients who use it to soak their lenses overnight. And when I wore soft lenses that I had to reuse, I myself used Clear Care. So definitely love that. Kills a lot of germs and viruses, and it feels good when you put the lens back in your eye. Okay.
Definitely. Sometimes just to add one more thing on that, I know you asked about water and I got into hydrogen peroxide solution, but sometimes it's nice to have both solutions. So sometimes I'll give my patients both, so like 2 different solutions, a multi-purpose solution and also a hydrogen peroxide solution, because say you want to take a nap midday or wear the lenses in the morning and then the evening, storing them in a multi-purpose solution would be a good thing to do if you don't have 6 hours in the middle of the day. So oftentimes it is fine to just have 2 different solutions there.
Totally agree. So some more questions. We have a very active audience today.
Excellent.
When wearing scleral lenses, should allergy drops be applied before the lens, or can you use the drops while wearing the lens?
Yeah, great point here. So we want to use the allergy drops before the lenses are inserted or after the lenses are removed. And the same thing goes along with drops for glaucoma or steroid drops. So all medicated drops should be used without the scleral lenses on, or contact lenses, I guess, and just in general. It is fine to use preservative-free artificial tears with contact lenses, any sort of contact lens. But great question there.
What length of time do you typically recommend patients to wait before they put their contacts back on?
Maybe about 10 minutes. So, for people who like to take a shower, for example, put the drops in, maybe take a shower, and then put the contact lenses in, because also we don't want to shower with our contact lenses. Same water issue here. So we don't want to get acanthamoeba due to shower water. So, well, yeah, what do you say, Gloria? Do you have a different answer there?
No, I think I would agree with you. I definitely try to tell patients to remove contacts in the shower or even hot tubs for that matter. And definitely if they plan on swimming in a pool or an ocean. We didn't quite get into that, but people for swimming, a question I get a lot is, I can't see anything, with my lenses. I can see so much better. Can't I just wear them in the pool? And I really prefer they avoid that, but I have made a few exceptions. If they wear really good airtight goggles on top of their lenses and they're not doing vigorous activity in a pool, that they can kind of be careful and do it, but as soon as they get out of the pool, to take their lenses off and rinse their eyes. What do you think about that?
I'm actually fine with swimming with goggles, with airtight goggles, and agree, to take out, put back in the lenses, or use artificial tears after. And I've learned that people walk in pools also. And
Yeah,
so
true.
I didn't know about this until, my patients are telling me they walk in pools. And so I recommend for them also to wear goggles,
Yeah.
because of the chlorine. But I'm actually okay with goggles and contact lens wear, because I understand it's hard to see without contacts.
Right, especially for our keratoconus patients.
Exactly.
Okay, let's see. Let me look at these questions here.
Sure.
So not so much dry eye, but keratoconus. What
Sure.
should I do if my keratoconus is so advanced that I can't use scleral lenses anymore? What are my other options?
Sure. So your other options, I mean, there are lots of different corneal transplantation options, but there were two good studies that came out by Karina Koppen and Jennifer Ling showing the benefits of scleral lenses, even for those with advanced keratoconus. So I'm sure Gloria too were very large referral-based practices. So even if your local practitioner feels like maybe you should get another referral, I might try a different type of scleral lens first prior to corneal transplantation. But there really are lots of options available. And just to be clear that not only corneal transplantation, but also if corneal collagen cross-linking is done to stabilize the cornea in early keratoconus, not severe keratoconus, we still need some sort of vision correction after the procedure, which can be a specialty contact lens.
Totally agree. And I want to chime in there that, I see a lot of keratoconus patients and some very, very advanced cases, very thinned, even with significant central scarring. But with a scleral lens, it doesn't really matter how irregular the cornea is because you're vaulting it. And so if we can get a good alignment, you will have compromised vision because of the scarring and the distortion. But sometimes even with significant scarring, I can get like a 20/50, 20/60, and sometimes that's functional enough for a patient. So it's really dependent on the patient and what their goal is and what they want to achieve with their vision, and is it suitable for their lifestyle. So in regards to that patient, I would say, what is your goal? And if this scleral lens isn't giving you functional vision, then as you mentioned, surgery may be the next step. But even after having surgery, you might still need contact lenses, whether it be soft or rigid or scleral again. So if it didn't fit your eye before the surgery, you might have challenges, after the surgery if it's a fitting issue, not just a vision issue. So I want to make sure our audience members know that a transplant isn't necessarily going to fix everything. You may still need contacts down the road, and it may get more complicated with the transplant. So something to keep in mind. Okay.
I totally agree, but also just to state, so it depends on the other eye. If there's another eye,
For sure.
the vision in that eye. So even if one eye, you're exactly right, one eye has scarring and gets 20/60 vision, well, what about the other eye? Is the other eye less advanced or less scarring and perhaps is able to get 20/40 or 20/30, which is, that combination is legal driving vision.
Yeah,
so, and
definitely.
very functional vision. So it definitely depends. So whenever vision is affecting my patient's day-to-day life, then it's time to move on to a corneal transplant. But just looking, let's search all options. And I work very closely with multiple corneal specialists to try and get the best vision and best comfort. And the answer is not always surgery.
Got it. So I am going to conclude with one more question here, kind of a two-part question. What are your thoughts on cross-linking? I got it done on my right eye and haven't seen any improvement okay, so the question says, I got it done with vision correction on my right eye and haven't seen any improvement. So I'm hesitant to do it on my left eye. Should I try cross-linking without vision correction? So maybe you can clarify for our audience,
Sure.
what is the intention of cross-linking? And then also, can you sometimes have dry eye after cross-linking?
Sure, sure. So corneal collagen cross-linking, the goal here is really to stabilize the cornea in those with keratoconus. So we want to prevent progression. And that's the importance also with this genetic testing that we have, is that we can detect and find keratoconus earlier because we want to prevent something like a corneal transplant. So cross-linking, the goal here is to stabilize and make sure that the cornea doesn't get more steep or change over time. So to answer your question, well, my question back to you would be, has the corneal curvature changed, or has the amount of astigmatism changed? So even if maybe you're not seeing a lot of visual improvement, could the vision be improved with a glasses correction or a contact lens or a specialty contact lens? And if there is progression in that other eye, I would definitely recommend cross-linking to prevent progression and to avoid a corneal transplant. And gosh, there's so many studies looking at the benefits of cross-linking that it's very, very helpful. Now, to answer the part 2 of that question, yes, I mean, dry eye can exist. And, I see keratoconus and dry eye hand in hand all the time. And so, yes, we do want to address the dryness even after cross-linking. But I think the most important point here with cross-linking is that it's not like a refractive surgery like LASIK or something like that. But cross-linking is done to stabilize the cornea, to prevent progression, which can really help in so many different ways over a person's lifetime.
Completely agree. I think we have hit our 6 o'clock mark for this evening. And I want to thank you so much, Dr. Barnett, for sharing so many clinical pearls and updates in dry eye for our keratoconus patients and even non-keratoconus patients. I've learned a lot. And we want to also let you know that our next evening webinar will be on March 8th. So in about 2 months, our topic will be contact lens options for individuals with keratoconus. I feel like we definitely got into that today. So for everyone who has more questions about contact lenses, our Dr. Stephanie Wu will be joining us, and she knows a ton about all different kinds of contacts. So thank you for joining us today. I realize I never introduced myself. My name is Gloria Chiu, and I practice at the USC Roski Eye Institute in Los Angeles, California. And it has been such a pleasure seeing you, Dr. Barnett, on webcam and listening to your talk. And I am positive that our audience today really learned a lot from you and enjoyed it. So we thank you for your time, and thank you everybody for joining us this evening. And we hope to see you in 2 months to learn more about contact lens options for keratoconus patients. So have a great night, everyone. Stay healthy, be well, and we hope to see you soon.
Thank you so much. This was so much fun. Have a great evening.
Bye-bye.